Welcome to the AOA Future in Orthopedic Surgery podcast series. This AOA podcast series will focus on the future in orthopedic surgery and the impact on leaders in our profession. These podcasts will focus on the vast spectrum of change that will occur as the future reveals itself. We will consider changes as they occur in the domains of culture, employment, technology, scope of practice, compensation, and other areas. My name is Doug Lundy, host for this podcast series. Joining us today is Dr. Jimmy Cook. Jimmy Cook is a board-certified veterinarian. He also has his PhD and is the director of the Thompson Laboratory for Regenerative Orthopaedics and the director of operations and research at the Mizzou Biocenter and the William C. and Catherine E. Allen Distinguished Chair in Orthopedic Surgery at the University of Missouri. As I said, he's board certified by the American College of Veterinary Surgeons and the American College of Veterinary Sports Medicine and Rehabilitation. He trained at the University of Minnesota and the University of Missouri. His research interests are focused on in vitro and in vivo models, tissue engineering, osteoarthritis, meniscal replacement and regeneration, articular cartilage, as well as other areas. I had the pleasure of meeting Dr. Cook at the Southeastern Orthopedic Symposium run by Dr. Jim Stannard, and I was immediately blown away by Jimmy's incredible knowledge of regenerative orthopedics, of PRP, BMAC, of all that stuff that's out there and the true nature of it. So, Dr. Cook, sir, welcome to the podcast series.
Thanks so much for having me.
And Jimmy, you are also one of the nicest folks I've ever run into. Thank you so much for all the work that you do for our patients and all the understanding on this. Can you just give the audience just an overview of what your work is, what your background is, and how you got into this?
Well, you gave a great intro. Thanks. I kind of came from the veterinary world and then went over to now what I say is work on the two-leggers full time. And so, as you mentioned, Jim Stannard, a great friend of both of ours, and my chair, and then just a wonderful clinician, scientist, and human being, brought me over here as we were kind of developing this area, to be honest with you. So both in the osteochondral transplant and meniscal transplant area of regenerative orthopedics, but then also in the orthobiologics. And so we really wanted to bring those forward in an evidence-based way. Certainly, we wanted to look at discovery and groundbreaking cutting edge, but do it in a really thoughtful and, again, evidence-based way.
So can you give us an overlay of what the current state is in the United States for however you would define? I'm not going to even put any parentheses on it. I'll let you figure out, you define for us what regenerative orthopedics is. What does that mean in the US and what are the current players in that?
Actually, I think you said it. And we're still in the defining stage, right? So I would say it's the frontier stage, which is good and bad. It's fun to be on the frontier and, we can explore new directions, but there's limited guardrails. And I think, especially when we talk about patient safety in combination with efficacy, and I always say it's what we're trying to figure out is what we can do, what we should do, and what we shouldn't do. And I think that's really where we're at. So again, the FDA guidelines for what we can use as indications are even not super specific. They're these general kind of minimally manipulated, not combined with other substances, homologous use, administered during the same procedure as collection. But that's a little tough too. And so again, I think it's really our responsibility, to define that for ourselves. And base that on the patient, base that on best current evidence. But then that's also going to help us in the long run, because the other, I think, difficult thing about the frontier era of this is it's hard to get insurance coverage, right? And you don't want to just cash pay. Number one, if it's not worth it, cost effective. But number two, we're never going to get insurance coverage if we don't kind of demand that based on the evidence.
So we're talking about stem cells here, right?
Yeah, my favorite. So honestly, for me, that's one thing if you use the terminology correctly, that is actually clear. So true stem cells cannot be used without IRB approval for a special indication in orthopedics today. And a lot of people, I think even orthopedic surgeons are going to say like, what? Everybody's using them. They're on all the billboards and all the advertisements. I see patients every week that paid X thousands of dollars for stem cells, but those are, and we have to use the air quotes here, those are stem cells in quotation. And they're not really that. And the problem is, I think we get confused of, what basic science or even translational science tells us about true mesenchymal stem cells, which are very powerful little cells and can kind of do all the things that we hope to. But again, based on current FDA regulations, we can't use those. It's actually illegal to use mesenchymal stem cells in clinics today without some specific IRB approval. And so the stem cells that people are using, again, in the air quotes, don't have that robust evidence. And a lot of times they don't work. And I think, not to scare anybody or be, too hyperbolic here, but, we've definitely seen some safety issues with the stem cells in quotation. So, yeah, we focus on all the other ones that are much more clear, I think, in terms of a legal appropriate pathway with some evidence-based indications in, level 1 and 2 studies that can safely help people if used as we should, not as we just can.
Right, right. And I love when folks come in saying, well, I had stem cells in us. I'm like, wow, in the US? And they go,
Yeah.
yeah. I go, that's against the law. Actually, does the Food and Drug Administration know about that? And their eyes get as big as saucers. And what they really meant was, PRP or something like that.
Right.
Speaking of which, what's the, as you see it, what's the current stand for PRP, if you want to throw BMAC in there as well?
Yeah, I mean, that's definitely what we're using mostly in this area of regenerative medicine, orthobiologics, is PRP. I think, it definitely has robust evidence, especially in certain indications. I mean, I think for mild to moderate osteoarthritis, we can be very confident in leuko-reduced platelet-rich plasma, autogenous platelet-rich plasma, as, being 70+% likely to have good pain mitigation and functional improvements in patients, at least with knee osteoarthritis. And I think we can expand that to some of the other joints. Get about a 75% successful response rate, if you will, for about 6 to 9 months. I think safety equivalent to placebo. So it's very safe. It's one thing I love about PRP, super safe. And then efficacy, I think, in level 1 studies, more robust efficacy than hyaluronic acid alone. And so that's definitely if somebody says, what is the evidence? Kind of like you just asked me, that's what I would say from there. I think the other indications are increasing. So we use it a lot, PRP for tendon, hamstring, epicondylitis, those other indications where we can jumpstart the healing process, try to speed up the healing process. But also then what's cool about PRP, right, is it's this biological soup. And that's what one thing you've heard me say before, and I try to always add in these conversations, is we're never smarter than God. And so I think, trying to give a super physiologic dose of one thing, like back to, BMP or even HA, those are basically super physiologic doses of one component of an incredibly complex healing, joint health, metabolism process. So what's cool about PRP is it's way more than that, right? It's a soup of kind of physiological during the healing process, 1,500 different proteins in every little platelet. And what's cool for us as orthopedic surgeons is a lot of them are geared toward musculoskeletal health and healing, anti-inflammatory, anti-nociceptive, anti-degradative, and so just along with then the growth factors and the things that stimulate healing. And so it's just cool. It's cool to think about, and it's cool to try and harness that for the benefit of the patient.
Very good. That's a great overview on PRP. What else is out there besides PRP that's, in your mind, is currently cool, acceptable, safe, and effective in 2024?
Perfect. I would say first I would finish up on PRP and say, so for us, almost all of those indications for PRP would be leuko-reduced, except for a chronic degenerative process. Because I think, we all know, we hopefully remember from our physiology classes that you have to have inflammation to get something to heal. And so it's just the right type of inflammation at the right time. And these degenerative processes, chronic ones, inflammation process has actually failed to jumpstart the healing process. And so we kind of restarted in those. So again, usually like a degenerative Achilles, maybe where there's some calcification around a tendon or calcification within the muscle, we might switch to the leuko-rich, so white blood cell high containing PRP to again stimulate that process and use all the other parts of PRP to try to get that going. For me, it's easy to then kind of get the algorithm. So leuko-reduced PRP for everything except degenerative processes, except when the indication has the word bone in it. So if the indication has the word bone in it, so tendon to bone healing, non-union fractures, stress fractures, for us, the osteochondral allograft transplantation, where we're trying to get osteointegration. As soon as you say bone as the primary thing in the indication, then we switch to bone marrow aspirate concentrate, so BMAC. So again, at least for us, it's a simple algorithm that we go through that way. And the cool thing about that is then you can really use the indications for label, which also then means insurance coverage pretty effectively in those ways. The only other thing that we're doing, quite honestly, in this arena is we are sometimes combining HA with PRP in the joint. I would say there's burgeoning, emerging evidence for that coming on. It does make sense to me scientifically because HA is one lubricant, right, that has some other properties, but HA is really mostly for cartilage on soft tissue lubrication in the joint. Superficial zone protein, or lubricin, is for the cartilage on cartilage lubrication. And what's cool about that is PRP has a bunch of that in. So if we take advantage of the HA, which PRP does not have, combine it with all the great parts, including superficial zone protein, lubricin, and PRP, then maybe we're even accentuating the PRP to the maximal level. Safe and effective. The biggest thing there, I think, is it's a bigger injection, and probably insurance is only going to cover the HA. So you're going to have to go back to the self-pay part for PRP, even if they would have covered it for something else. So that's the only, I think, thing we have to navigate when we're trying to combine those. But in terms of safety and efficacy, we've been really happy with that one. I'm definitely keeping an eye on things like amnion, but I just, haven't seen the evidence yet. And I'm just not sure that when you break it down to its components, at least for in the joint and the primary musculoskeletal indications that we typically talk about or reach for regenerative orthopedics or biologics, I'm just not sure the components are really geared toward that. It's definitely not as diverse of a composition as PRP. And it's really, more of a, I guess, early process developmental. I mean, that's where it is, right? It's in utero or in the placenta. And so, I just think it's kind of geared toward a different thing. I mean, that's why I would say is, it's kind of funny we talk about this topic because I think, really regeneration is pretty impossible once you're an adult. So what we're trying to think about is more effective repair, better remodeling, better tissue health. And so again, that's where I think coming back to the things like BMAC and PRP, where it's geared toward healing tissues that have been damaged rather than developmental biology, if you will. It just makes more sense to me in a real world orthopedic practice.
So that's very interesting. So you touched on the amniotics. There's like adipose, there's a lot of other players in the mix. Any thoughts on any of that more fringy kind of restorative stuff that's out there now?
I really think those are all, and this is opinion, but is based on lack of evidence, I would say. So everything I've tried to say up until this point was based on evidence, clear evidence. Now I'm saying opinion based on lack of evidence. And that always scares me because it's being used so much. But I think, adipose-derived stem cells, again in quotations, even bone marrow-derived stem cells, again in quotations, for the indications that we're talking about, I just have not seen the evidence. And we totally avoid them because the other reason is, I mean, without that evidence, they're all way more expensive and zero covered by insurance for orthopedic indications. So here, let's just compare it straight up, right? PRP, probably the most I've seen for a single injection around the country is around $1,200 cash pay. Here, it's honestly, the PRP part is $250 for a single injection. So even if you have that range, and then you compare that to what, even in town here in Columbia, Missouri, or what I've seen across the country is more like about 1,800 to, I've seen for a single injection advertised $11,000 for adipose or bone marrow derived stem cells in quotations. And then about 50% of our PRPs are covered by insurance now for knee osteoarthritis, and 0% across the US are covered for stem cells by insurance, stem cells in quotations by insurance. I mean, it seems pretty clear, right? Like you just stack up those comparators and you say, why would I do that? Especially when then the efficacy evidence is completely in favor of PRP or BMAC.
I've got friends who unfortunately have got pretty significant metastatic cancer, and the oncologists here in the US have basically said, you're now in palliative care, and they don't want to give up yet. So they have taken their life's resources and gone to certain countries outside the US and paid for incredible treatments, and I'll put air quotes on those, that to date, every one of those friends of mine have had no benefit to their cancers and have died from it, unfortunately. But I've also been aware of patients who have left the country in search of restorative biologics and stuff. Any thoughts on where that's the status of that is out there currently, in terms of outside of the United States, outside of the developed, necessarily probably the developed world, developed Europe and such, and other places where we should be a little wary?
Yeah, that's it. I mean, be wary for sure. The really frustrating part to me about this whole thing is true mesenchymal stem cells can have amazing effects. Honestly, probably truly regenerative effects in some applications and indications when used correctly and safely and all of that. So I don't want to throw those out. And I think, again, every time I just probably ad nauseum just say, like, we really got to be careful of semantics, because everything that we're using in the US, and unfortunately a lot of those other ones, are the who knows what, the stem cells in quotations, and potentially very dangerous. If and when, and in some indications, when we or other places in the world can use true mesenchymal stem cells that are shown to be that, and you have to show that by a bunch of different scientific tests, to say they're true mesenchymal stem cells in some indications, I think that can work. I'll be honest with you, I'd be hypocritical if I wasn't saying this, because fortunately we're just part of a big ARPA-H grant that is using stem cells to tissue engineer whole joint replacement. It's a moonshot. I don't know if we'll get there, but I mean, it's possible. And wouldn't that be amazing if we're able to do that and truly regenerate a whole joint or parts of a joint that could, really move the pendulum, move the needle in terms of truly regenerative, restorative joint replacement surgery. But we're not there yet. And we got to be super careful, especially if it's in these areas where it's, not regulated, not really under the careful microscope, no pun intended, of regulatory bodies that are going to say, like, safety first, man. I mean, and especially if nothing else, safety for your checkbook, right? I mean, we've had people come to us that have spent over $100,000 on stem cell injections or other regenerative treatments, including in other countries like you've talked about. And again, not only no benefit, but some of them had, inflammatory arthritides, immune-mediated problems from that, septic joints. So it's again, we got to be super careful with it. And I think, I don't know of any place that I could say safely does true inside this country, outside this country, does that safely at this time point where I would say, like, yeah, it's worth a try. If you're at that point, like, I'm going to lose my leg, I'm going to lose my joint, I'm going to, die of cancer. I still don't know of somewhere where it's regulated enough, but cutting edge enough to say that compassionate humanitarian care is worth it, if you will.
Right. That'd be crazy if y'all could get entire joint replacement not just from, but from these restorative methods. All right, which leads us to the next part. Where do you see this going? And you could pick your future timeline, whatever you'd like it to be, 5, 10, whatever years ahead, even further. What will this look like in Jimmy Cook's mind out there in the future, in terms of just the direction you see of how we'll end up?
Yeah, I think I see two ways. I mean, one is, I think, just expanding this current one, because again, I do think we have great arrows in the quiver. I think PRP and BMAC are great arrows in the quiver if you use them well. So I just like to get those arrows clear in indication so people are speaking the same language. Like when we say I gave a PRP injection, what does that mean? So we can compare apples to apples in different studies. And then, also along with that is just get like insurance companies. It honestly kills me, and I do get it because it's so complicated. But at the same time, I don't, because PRP has level one evidence, meta-analyses that is better than HA. But insurance companies will still pay for HA, which is more expensive, and not PRP. So I just say, like, let's just get it pragmatic and practical for the patient. Like, and it still benefits the insurance companies, right? So let's just get that where we're using the same thing, we're talking about it in the same way, and we're getting it paid for to help patients, which will move that part. I think that will move that area vastly far forward, because then we can do those studies, those registries that really say, like, when does it work? When does it not work? What's can, should, and shouldn't in this frontier? And then we move off the frontier and we just know what we're doing for patients. The other part then is the really, moonshot pie in the sky, holy grail part, which is regenerating joints. So I think biological, whether those are allografts, of different types, or truly tissue engineered regenerative medicine. I mean, I think it's cool that ARPA has, put the money into saying, like, this is crazy. I'm like, it's going to be the coolest thing in the world if we can do this, but let's give it a try, because we're going to learn stuff and we're going to move something forward. I mean, better than I do that metal and plastic are awesome for the right patient. I mean, there's so many people that are happy with their artificial joints, and there's so many people that aren't, and that want something different, right? And so I think if we can just dial that in and have something that truly could be regenerative, or at least as joint preserving, restorative as possible to return function in these young patients. The average age for artificial joint replacement is going down, which is a little bit scary.
Yeah.
And so trying to get those two avenues going, I mean, that's my dream. My dream would be that, biologics are part of a comprehensive care center in every orthopedic institution, and everybody knows what can and can't be done and what should and shouldn't be done in both of those realms.
It's interesting because part of what you're also talking about on the payer side is there's a move, especially out of certain places like Texas and in Nashville, about moving off of procedural based bundles and onto diagnostic based bundles. So you could easily see in the future that this restorative medicine will be part of a knee pain bundle where the 70-year-old with the destroyed knee goes on to total knee arthroplasty, and the 45-year-old with a big MFC injury could enter the restorative side.
Yes. Yeah. I mean, I would love that. I mean, that's exactly what I envision. I think is the right thing, right? I mean, that's what, and just those options that patients and, healthcare professionals understand what the options are and how they would be cost and efficacy effective, value-based, truly value-based, right? Care moving forward.
Anything on meniscal transplants? I know you work on that as well. Anything you see where that's going?
I mean, that's part of it for me. I think we've really shifted toward viable, so fresh meniscus transplants, and our early results are showing that. So again, the same kind of thing, like truly biologic, not just a dead piece of tissue that can serve a biomechanical function, which can be good, of course, but the truly biological part. I always say that biology and biomechanics are inextricably linked in orthopedics, and you really can't have overall success without kind of combining those and augmenting those together. And so that's really what we've tried to do, is take it to the next level, truly make it a biological meniscus transplant and a biological cartilage transplant, and hopefully let those donor cells do their thing in the body and kind of keep it longer term and more truly functional in the joint.
Any other futures in regenerative stuff that you're thinking of?
The only other thing I would say is I would like to see, like you were talking about, is the truly cutting edge stuff, but under a safety net. So, if we can say this is high risk, but you're fully informed, it's maybe a humanitarian situation, whether it's loss of life or limb or loss of quality of life, right? And say, like, with all that, fully informed under the guise of at least safety, you're taking more of a risk on efficacy. Let's try that in a center that's geared toward this, that's going to do the comprehensive patient care That gives you the best chance for that. I would love to see that. I mean, I think that's difficult and risky, both medico legally, and just efficacy wise. But I think if done right, like some of those, I think about things like the Center for the Intrepid, right? That's trying crazy stuff to save our amazing, veterans and service members' life and limb. It would be cool to do that in this area as well.
Wow, it's been once again an absolute pleasure to discuss restorative, regenerative biologics and surgery with Dr. Jimmy Cook, who is the director of the Thompson Laboratory for Regenerative Orthopaedics at Mizzou, working alongside all the great orthopedic surgeons out there at Missouri and trying to find the restorative ways and the best ways for us to use these new and interesting biologics coming down the pike. And if you haven't heard it already, Jimmy knows more about this stuff than anybody I know. So, Dr. Cook, thank you once again so much for being on the AOA podcast.
Thank you. It was really fun. And I learned a lot too. So thanks.
Thanks, Jimmy. All right, y'all, and stay tuned for more futures in orthopedic surgery in the podcast series by the AOA. Thank you.